This is Population Health Weekly. We bring the science to your street. One small habit, one clear choice. Right where real lives meet. Every voice, every choice, every truth that we share. Public health is
In the month of February 2024, a single missing login safeguard brought a North American healthcare giant to its knees. A ransomware group accessed a portal without multi-factor authentication. They moved undetected for days, exfiltrating terabytes of data. By January 2025, an estimated 190 million patient records had been exposed. Pharmacies could not process prescriptions. Hospitals could not verify insurance. A subsequent survey reported that 74% of hospitals face direct patient care disruptions.
endless. If we dare to listen.
Welcome to Population Health Weekly with me, Shahnur Azhar, on July 17th, 2026. In previous two episodes of ongoing series Click, Care, Connect, we have discussed how digitalization is shaping healthcare and driving regulatory response. To do it, we identified five players: patients, hospitals, tech manufacturers, insurers, and governments. Today, we present the emerging landscape reshaping our neighborhoods, colleges, and workplaces, and how it concerns all of us. But before everything else, welcome to my co host, Erin Rodgers.
Hello, Shanor, and hello to all of our listeners. The second half of today's show sees the return of the Triad, a collection of three updates from the biomedical world, and the three keywords that come with it are TB vaccine, dentistry, and herbs. Back to Shanor as he builds further on the hacking incident presented earlier.
Turned out that it was not a nation state attack. Basic security was overlooked. Infrastructure crumbled because it's never all about just servers and hardware. It's the governance that links three parts, or pillars, as we will call them in this episode, and they include physical spaces, digital networks, and human skills. If one pillar weakens or falls, the whole system collapses. Let's begin with physical spaces. The appetite for big data storage, including that of healthcare, is pushing land based data centers into neighborhoods and compete for water, electricity, and land. A single facility can consume as much power as a small town. Communities push back, and their concerns are valid. Undersea data centers are already being activated, with space based proposals on the horizon. In low income settings, it's probably not yet an issue. But what's clear is that the footprint of digital or e health is no longer just urban, it is planetary. Let's turn to digital networks: Wi Fi, cellular towers, public sensors, connected to indoor installations and portable devices. This ecosystem enables telehealth kiosks, smart defibrillators, and remote monitoring. But the same connection that brings care invites vulnerability. The data breach we mentioned at the start was not a hardware failure, it was a network governance failure. Protocols never enforced. As analyzed in previous episodes, if advanced technology cannot bring uncontested fairness to professional sports, it demands even greater scrutiny when it touches human lives. To discuss our third pillar of human skills, we return to Al Rashids, the family helping us navigate through this series. Its two generations have shown different faces of the same challenge. The adolescent son Khalid has now become a medical student. Along with basic and clinical subjects, he must understand how data centers store records, how networks transmit them, and how algorithms reach conclusions. He must also learn to train equitable AI models built on local data, free from dataset imbalances. Khalid's parents, Laila and Umar, represent a different timeline. They are working adults, not students. Like millions of working adults worldwide, they're also being asked to adapt to digital or e health systems with no training, no support, and no fallback. This is the human cost of infrastructure built without governance in several places. And the cost is mounting, not just in anxiety, but in all currencies. The same governance gap that allowed the data breach is now tempting employers and governments to underinvest in workforce retraining, leaving millions like Layla and Umar to fend for themselves. This is why retraining is infrastructure, not overhead. The Health Foundation, an independent organization in UK, estimates that £21 billion will be required over 5 years to digitize NHS and adult social care services, with sustained investment in staff skills, not just hardware. In rural India, a 10-month pilot to train community health workers in digital tools dedicated 61% of the total cost of over 200,000 US dollars to personnel. While the digital or e-health market, including procurement of training infrastructure at medical schools, is expected to continue its double-digit growth in near future, these investments are meaningless unless they strengthen all its three pillars: physical infrastructure, digital networks, and human skills. The generation of medical student Khalid will benefit, but his parents' struggles cannot be forgotten. Without retraining, without safety nets, the promise of digital or e health will remain out of reach for patients, caregivers, and the workforce. Yet the most interesting investments are in places where necessity drives ingenuity. In lower income settings, frugal innovation is leapfrogging traditional infrastructure. AI powered tuberculosis screening cuts testing costs by over 60% in high burden countries. Low cost wearables paired with messaging platforms, provided they comply with health data regulations and cater to all literacy levels, deliver care where clinics are hours away. Offline capable Internet of Things system detect chronic disease without constant connectivity. The Global Fund invests approximately 150 million US dollars annually in digital or e-health and information systems across more than 90 countries. Zimbabwe's national HIV prevention tracking system is one such example. Utilizing the District Health Information System 2 or DHIS2 tracker to monitor and evaluate HIV risk, service referrals, and health outcomes for vulnerable groups. These are not passive recipients. They are active innovators challenging our assumptions about infrastructure. Despite their ingenuity, these low cost solutions carry a hidden cost, one that rarely appears on any balance sheet. The same variables that extend care eventually become waste. E waste threatens all three pillars: physical, via landfills, digital, via hardware lifecycle, and human, via the health of workers in the global south. In the absence of formal recycling, much of it ends up in informal dump sites. There, workers, including children, dismantle electronics with bare hands, exposed to lead, mercury, cadmium, and brominated flame retardants. Toxins that cause neurological damage, DNA harm, kidney and hormonal dysfunction, and increased chronic disease risk. Children, pregnant women, and their environments are particularly vulnerable. This is the paradox. Devices designed to improve health in one community are quietly harming another. The scale is staggering. According to UN Global E-Waste Monitor 2024, the world generated an estimated 62 million tons of e-waste in 2022, enough to fill nearly 1.5 million 40-ton trucks. This e-waste generation is projected to reach 82 million tons by 2030. Yet only a fraction of this e-waste is formally recycled. The rest ends in landfills, incinerators, or the very communities leapfrogging with frugal innovation. Healthcare contributed about 83 million new medical wearables in 2020 alone, with nearly 20% annual growth projected through 2027. As indicated in reports from World Health Organization and International Labour Organization, this already is a crisis. And newer data centers compound it. Each server rack adds to the mountain we refuse to acknowledge. And the relentless pace of progress is always presenting with a newer model, a faster version, and an update. Unlike a video review, there is no replay button for the health of workers exposed to e waste. The irony is bitter. We once celebrated the end of dusty warehouses filled with paper records. We imagined sleek servers replacing them. But what is replacing those warehouses? Not empty spaces. A new mountain range of discarded smartwatches, used monitors, obsolete tablets, and a toxic legacy of electronic junk. Much of it from very hospitals that promised a cleaner future. The same governance gap that exposed 190 million health records in a massive data breach in a highly advanced setting. That is tempting employers and governments to underinvest in workforce retraining, is also poisoning communities in the global south. Just as video reviews cannot always undo a wrong decision, our high tech infrastructure cannot undo the damage of unmanaged e waste. The infrastructure will fulfill its promise of truly better health outcomes for all of us only when all of its three pillars are governed smartly. Next week, we visit India, Rwanda, and Spain. Stay with us.
Wow, it's amazing how the healthcare landscape has changed. And now it's time for the Triad, a collection of 3 updates from the biomedical world that we present fortnightly or every third week. It also comes with 3 keywords of the day, and today's keywords are TB vaccine, dentistry, and herbs. Our first story looks at tuberculosis, the burden, challenges, and the progress that's been made so far. Tuberculosis remains the world's top infectious killer, with an estimated 10.6 million cases and 1.3 million deaths in 2022. The burden is concentrated in 30 high incidence countries across Southeast Asia, Africa, and the Western Pacific, disproportionately affecting low and middle income populations, though drug resistant TB does pose a growing risk in all income groups. Persistence stems from underdiagnosis, social determinants like poverty and malnutrition, and weak health systems. Latest efforts include expanded molecular testing, shorter all oral regimens, and stronger community based care. Without accelerated action, though, 2030 NTB targets will be missed. In vaccines, the M72/ASZ1E candidate has entered phase 3 trials, offering hope beyond the centuries-old BCG vaccine. And in our second story, let's look at how 3D printing can reshape dental practice. Putty, patience, and praying for good impressions, those days are over. Increasing adoption of 3D printing is transforming dentistry with faster, precise workflows. Most favored procedures, including surgical guides, crowns, bridges, aligners, denture bases, and orthodontic models, enabling same-day restorations. However, 3D printing does not perform well for high-strength permanent posterior crowns or implant-grade metal frameworks, where milling remains superior. Future projections foresee falling printer and resin costs, expanded digital training in dental curricula, and chair-side printers as standard. Small clinics and lower income regions will benefit, but infrastructure updates such as scanners, software, and ventilation, and staff retraining remain essential barriers to equitable adoption. And in our final story, we look at the research and market interest in herbal and traditional medicine products. Global research and market interest in herbal and traditional medicinal products is growing rapidly. As of 2024, over 2,000 active clinical trials are registered on clinicaltrials.gov for herbal interventions, a 40% increase since 2018. Highest trial activity is seen in China, India, Germany, and Brazil. The global herbal medicine market was valued at approximately 85 billion euros in 2023, with an annual growth near 7%. Traditional products are widely used for immunomodulation, metabolic disorders, and mild infections. While interest from investors and consumers is rising, rigorous efficacy data remains limited. The WHO Traditional Medicine Strategy 2025 to 2034 aims to integrate quality-controlled herbal products into primary care, further stimulating research funding and regulatory harmonization. That's it for now, folks. I'm Erin Rodgers. See you next week.
Technical support for this show is provided by Wahab Shahid. Podcast logo, theme music, creative and production advice is given by Imran Babar. Erin Rodgers is our editorial associate. Population Health Weekly is led by its listeners, and they are invited to participate in any competent way they can. If interested, email us at info@ideas.org.s, info@ideas.org.es.
Subscribe to our YouTube channel, Population Health Weekly, where you can also post your thoughts, comments, and imaginations. You can also subscribe to our monthly newsletter on our website, ideas.org.es. It's free. You can also donate to us through ideas.org.es and the hosting platform rss.com. All contributions will be dedicated to improving the quality of this show. The transcript of the show will be available as soon as it's posted via rss.com. If Population Health Weekly sounded interesting to you, then spread the word.
Special thanks to Junta de Andalucía and Gobierno de España for their support to Autónomos that made this production possible.